Ladies and gentlemen, good afternoon, and welcome to what we hope will be an edifying and enlightening discussion this afternoon of some very significant legislation that's been introduced by our friend and colleague Congressman Kennedy from Rhode Island and our friend and colleague Congressman Ramstad from Minnesota. The legislation bears the distinguished name of the late Senator Paul Wellstone in the state of Minnesota, who worked very hard for the issue of mental health parity. And that's going to be the issue that we have in front of the subcommittee this afternoon. There are 44 million Americans who are dealing with some kind of mental health issue in their lives. But only about 1/3 of those Americans are receiving care from a qualified, trained, prepared mental health professional for their issues. When asked why the other nearly 30 million did not receive care, an overwhelming majority of those individuals indicated that their problem was related either to insurance or the cost of insurance. 87% of those who are not receiving mental health services but who need them indicated that there were issues with their insurance policy which precluded them from getting that care. And 81% of those who did not receive care indicated that cost was a major consideration in their failure to access the care that they need. Now, 42 states have understood the problems with our present insurance system, and the problem, I think, succinctly can be summarized this way. It is presently acceptable under the law in many cases for an insurance policy to distinguish between a mental health issue and a physical health issue. So, for example, a person who injures her knee may have a $500 deductible toward dealing with a knee injury, and then after that, the insurance kicks in and pays a substantial part or all of what is yet to come. And typically, the number of visits the person would need to get their knee fit and trim is either unlimited or doesn't have much of a limitation on it. So as many trips to the surgeon as you need, as many trips to the physical therapist as you need, you get those trips until your knee is sound. On the other hand, if a person suffers from clinical depression and he or she needs the care of a psychiatrist, that person may find that there is a $5,000 deductible before the insurance policy begins to pay most or all of the cost of that psychiatric care. The person may also find that if they're fortunate enough to have the psychiatric care, there may be a very low limitation on the number of visits that he or she is permitted to make in a given year. So instead of as many visits as you need, you may find that you only get 3 or 4 or 5 of them, whether you are fully healed and prepared to deal with the rest of your life or not. I think these distinctions are arbitrary and unwise. And this is a view that has gained great currency around the country. 42 states have enacted some form of mental health law. Now, these are a mixed bag. Some of these state laws require specific mental health services. Others require a sort of parity between the care of physical and mental health issues. And still others will deal with requirements that insurers and employers must offer mental health coverage without any requirement that the coverage actually be provided. These are noble efforts by the states, and we're going to hear from a distinguished state insurance commissioner from Wisconsin later on the second panel about a very excellent effort in his state. I don't think they're sufficient for 3 very important reasons. The first important reason is that members of our society who are part of ERISA plans, that is, health insurance plans governed by the federal statute over which we have jurisdiction, are not affected by or protected by these state statutes. So the 52% of our workforce that works for an employer that's covered by an ERISA plan does not have the benefit of the state law statutes in these 42 states. Second, many of these statutes are limited in their reach. They don't solve all the problems that we set out to solve. And third, I believe that many of these statutes don't particularly fit together well with other federal efforts to deal with this problem. So it's my view that we do need a strong and well thought out federal standard to guarantee mental health parity. And I am a supporter of the efforts of Congressman Kennedy and Congressman Ramstad. I understand there's issues, and we want to hear those issues fully vetted today. But this effort by Congressman Kennedy and Congressman Ramstad has very broad bipartisan support. It is by no means the initiative of the majority party. It is the initiative of many like-minded members on both sides of the aisle from around the country. And I believe that it takes us in a direction where we can be successful. Final point that I want to make before I yield to my friend from Minnesota. Very often when we try to expand insurance coverage, we get into a debate about whether the cost is worth it. And that's a debate we absolutely ought to have. We're going to hear this afternoon from an actuarial expert who will provide some compelling evidence that the results from the field show that the cost of extending true parity, which is what the Kennedy-Ramstad bill does, the cost of extending true parity is very low. The testimony will indicate that it's 0.6%, which is quite a low number, and I would point out that that is a gross number. That is a number of the projected increase in the insurance premium before one takes into account productivity gains, reductions in absenteeism, other physical health gains that would take place as a result of the implementation of such a policy.